This is Vernal. Can you see and hear us?
That's right.
We can hear you. Can you hear us?
Yeah.
We can hear you.
Not funny, but very funny.
You're a woman of your word. Hey, coffee.
It tastes so good, too.
Hey, thanks.
Yeah, it was.
Usually take notes.
Stop.
I'm like a merciful God. You take me right now.
You did not. That's how I feel.
Good morning. It was a little subdued this morning. Cold. Very chilled out there. But let's go ahead and get started. I think we have a full meeting today, so I think it's probably worthwhile taking every minute that we can. And if people come in a little bit late, that's not a problem. So welcome, everyone. We have a number of people who are also on GoToMeeting, and we will say welcome to those folks as well, along with our slides. There we go. So we'll start today with some introductions like we usually do, and then we'll move on to a little bit of housekeeping and some announcements, and then we'll get into the main part of the meeting. So I'll start. My name is Mindy Tueller, and I manage and I facilitate this meeting, and I think most of you know me. So it's great to see you all here, and again, we're happy for anyone who wants to connect with us remotely, PUS, and those on the call with the meeting. So let's go ahead and we'll go through the room and introduce ourselves and make sure that we introduce the rest in the GoToMeeting folks. But we may end up just sort of reading out who she is. Go ahead, Gabby.
All right, so my name is Gaia Baragoshi. I'm a quality improvement specialist at UPIC, and yeah, that's pretty much it. On GoToMeeting, we have Natalie Allen. Natalie is a nurse practitioner with integrated services for children with special healthcare needs. Then we have Dawn Bentley on the phone on GoToMeeting. She is also a QI specialist working with me in UPIC. Then we have Walt Torres. Walt Torres is also from Integrated Service Program. We have Amy Spears. Amy Spears is a care manager at Holiday Pediatrics. Then we have Kelsey Hondu. She's a care coordinator at San Juan in Land. Then we have Brittany Guerra on the phone. She's from the health department from the asthma program. Hi, Brittany. We have Linda Dibbles. She's a care coordinator at Utah Valley Pediatrics. And then we have Linda Stephenson on the phone on GoToMeeting. Linda, can you introduce yourself quickly? Okay, we have Chan Boca on the phone. Chan, can you introduce yourself quickly? We also have Elba Magana on the phone. Elba, can you hear us?
Sometimes what we find with the meeting is that people are muted, and we figure out how to unmute and talk. If you're not able to talk, that's fine, and you can also type in the chat box if you want to tell us who you are.
We also have Cecily Tillman on the phone. Cecily, if you can hear us, or if you can unmute yourself, please introduce yourself. All right, well, I think you can go ahead and introduce, and then please write in the chat box if I can read it out loud then.
Sure. All right. Okay, Pat, are you going to?
I'm Pat Rowe. I'm a pediatric nurse care manager with Select Health Insurance.
I'm Cassie Crane. I'm a care coordinator at Wasatch Pediatrics South Point. I'm Neva Stevenson, Physician Liaison at Shriners Hospital.
Anna Reese, Southwest Children's Clinic Manager.
I'm Angie Richens. I am a case manager and the behavioral health manager at Alpine Pediatrics.
Greg Hawks with James Mason Centers for Recovery. I do the marketing and community outreach.
Hi, Eric Christensen. I manage the Integrated Services Program with the Utah Department of Health.
Carrie Martinez, a care coordinator with the Integrated Services Program.
With the Connector Service at Primary Children's.
Sharon Norda, I'm a care coordinator with the Rainbow Kids team at Primary Children's.
Gina Money, Utah Parent Center and Utah Family.
Kay Haynes with the resources on the medical home portal.
Chuck Norland, general pediatrician and
I'm Perry, Southwest Children's Clinic care coordinator.
I'm a care coordinator at the Clinic 6 Pediatrics at the University Hospital. My name is Chloe Kirkpatrick.
I'm Rebecca Barker. I'm also a care coordinator at the University Pediatric Clinic.
Heather Castor, Med Home for Wasatch Pediatrics.
Our GoToMeeting people aren't able to hear. So I can certainly use this, but for those of you who don't have your own personal mic.
I know I forgot something today.
So these boxes up here, these squares that you see in the center of the ceiling with the green light, those are our mics for the room. And so if you want to just sort of project that direction when you're speaking, that will help our GoToMeeting folks to hear as well. And then for GoToMeeting people, if you don't mind muting yourself if you're not talking, that would be helpful. Oh, interesting.
Really?
Okay, let's see what we can do. Oh, well, that might help if I unmute myself.
Linda.
Hey, GoToMeeting folks, can you hear us now?
Okay.
Yay! Okay. Surprisingly, you have to not mute yourself to be heard. Great. Okay, well, we apologize, guys. We've just been going through introductions, so you really haven't missed anything. And we basically introduced you for yourselves.
Yes.
I will mention at this point, though, that it's very helpful for us to know who attends these meetings. And so sometimes if you call into GoToMeeting rather than log in on a computer and call using kind of those codes and numbers that we send out, we only see you as a caller. And so we actually have, I think, a couple of people who either we don't know your name because of the way that you logged in or you called in only, and so we can't tell who you are. So it would be super helpful if you could actually shoot me a quick email if you are a GoToMeeting caller and let me know you attended today. It's much appreciated. It's used by a number of our groups in helping support this effort through reporting and that sort of a thing. So great. All right, terrific.
Do we get to introductions from our friends out in TV land?
Oh, oops, sorry, Wes.
Thanks, Eric.
Wes, tell us who you are.
Wes Smith with Tri-County Health Department. I'm a care coordinator.
Great, we're so happy you're with us. Thank you.
And we have Gwen and Sarah from Southeast here. They are logged in as SHCN coordinator.
Okay, great. Terrific.
We're listening on the phone also.
Excellent. Okay. Welcome. Happy to have you with us. All right. So we'll just get started now with just a little bit of housekeeping. So there are bathrooms available. Feel free to take care of whatever anytime. This is a pretty informal group, and they're just down this hallway as you exit this door and kind of in the center part of the building, just past the desk where there's someone sitting there. If you need Wi-Fi, there's a Blue Zone network that you'll see here, and there's a guest option there. And then we are recording this meeting, and the recording ends right at the stroke of 10, so we'll just need to watch the time because that's a big shock, and Wes goes poof. So we'll pay attention to that. Okay, so we just wanted to mention some updates that have been happening to the medical home portal. We have quite a bit of content that has been updated or even some new content, so we just want to make you aware of this. Most of it is in our clinical side of things. And so we have a number of diagnosis modules that have just been updated, including Cornelia DeLong, transgender and gender diverse. That was a relatively new module, but it got an update because of an AAP guideline that was just released. Down syndrome just got a major overhaul. Our headache module got updated as well. And then we have some screening or other more kind of focused pages that have also either been just published or updated. So we have a new page on screening for sleep problems that's just been published. And we have some information on dental and oral health screening that's been updated and procedural anxiety that's been updated. So we hope that you'll check those out. And we love your feedback. So if there's something that you see that you have a question on, that you'd like more information on, that you don't think is quite right, all of that input is really, really appreciated. So we'd love to hear from you about our content. And then we just wanted to mention also that we're continuing a number of projects. We actually had a little focus group around our service provider lists, and thank you for those people who contributed to that. We're continuing on that project. We're in a pre-phase where we'll probably come out again and ask for some more input, some more help on that. We continue to try and improve our service categories. I think some of you may have been here when Linnea Bauer joined us in person, and she's a new staff member, and she's working very hard on both the list project and getting our service categories cleaner, clearer, working better. And we also have a project around improving the search on the medical home portal. And then we wanted to let you know that we're going to be attending a conference in March called the AMCHIP Conference, and that stands for Association of Maternal Child Health Professionals, I believe. Is that correct? Sound right, guys? Okay. And it's an annual conference that brings together really a lot of these kinds of stakeholders from all 50 states and other kinds of organizations in the U.S. So maternal child health, Title V, those children's special health care groups. And so we're excited that we're going to have a medical home portal poster there, and we're going to have a medical home portal booth. And we're hoping to get some interest from states that aren't already partnering with us. And we'd love to kind of get your perspective on what we might tell them if, for instance, we had the opportunity to talk to a care coordinator, such as yourselves, from another state there. I'm not so sure that we'll get that particular audience attending there, but perhaps some of their supervisors or people who work with them. So we'd love to get your thoughts on that. And again, this is also an opportunity for you to tell us things that maybe we aren't going to go sharing and talking about with others, but that can help us improve the medical home portal. So we're always hoping for that feedback. And you're very welcome to share that with me now, share that with us now, or we can ask for that to be conveyed in different ways. So you can email me or talk to me after the meeting, anything like that. But we'd love to get your ideas on what makes the medical home portal a tool that's of value to you. And one of the things that we plan on doing before that conference is to update some of our care coordination information on the portal, because we really do see it as a tool for people who have the kinds of roles that you guys do, regardless of what state they're in. And that's our aim and our goal, is to make it particularly useful for folks like you guys to help connect those families with the kinds of information that they need and the kinds of service providers that they need. So I'll just throw that out there for a minute. Yeah, Pat.
I refer a lot of my parents to the portal because there's resources there that I don't know about that everybody else has contributed, and they think they're just stuck in the insurance and of itself is complex. But I think that they need to know that there are more resources, and if nothing else, they can access support groups that are local instead of online. Sometimes they can be face-to-face or whatever it is. And I think that that's huge because it gives them another option. And anytime we can give parents options, I think we're doing them a service.
Great. Well, that's very helpful. Thank you for that perspective.
Yeah, I know I'm the only insurance person here, and I'm on that dark web, so to speak, of complexity, But this whole group is so incredibly helpful to what I do. I wish there were more pediatric insurance people here, because there's a whole lot of complexities within the insurance world, and parents simply don't know what their options are.
Right.
They don't know how to access appeals. They don't know that they have certain benefits that they really just don't know about benefits. And I would also tell your people at your conference, contact their insurance companies for options, partnership with them instead of being angry or frustrated.
Right, push them away. Yeah.
Yeah.
No, that's really helpful. That's a good idea. Yeah, we'd love to see more of these kinds of groups, or become aware of them if they already exist, and have them connect in to the medical home portal, because I really do think that it's this personal interaction and this crowdsourcing and networking that occurs here that can be such a valuable source of input for the medical home portal, so that it becomes this circle, right? It keeps improving as a result, and we all keep improving as a result as well. So, great, thank you. That's super helpful. All right, well, I'll let you think about that for just a little bit, and we can go ahead and move on to the brainstorming part of the meeting prior to our presenters, who I think will probably be joining us right around 9. So again, this is your time, and this is where we encourage the GoToMeeting folks to type in the chat box or unmute themselves and try and use the phone. Oh, and maybe Gabby's got someone.
Yeah, I think Dawn Bentley, she would like to make an announcement.
Okay, great.
Hi, like Gabby said, this is Dawn, and I'm one of the QI specialists with Gabby at UPIC. And I just wanted to let everyone know that we are going to be doing a QI project mostly focused on care coordinators and care managers, and your role in caring for patients with autism. And it will probably just be one measure, and it could be pre-visit planning and phone calls or care plans. But anyways, just wanted to kind of throw that out there as an opportunity. If you're working on improving your care that you give to patients and families with autism, if you can just let me know right away. We're actually doing this in conjunction with the Peds Tel Echo module that just started a few weeks ago on autism. And if you want information on joining, registering for that, those calls as well, I can let you know about that.
Thank you, Dawn. So does everyone know about UPIC? See a lot of heads nodding, but maybe not everyone does. So Dawn, if you are still unmuted, do you want to just mention quickly what UPIC is?
Sure. We do quality improvement projects with clinics in the community mostly, and most of our projects have been centered around a certain diagnosis, and a lot of it is what's charted in the medical record and centered around the provider. And so that's how this one is a little bit different, is it will be, what are you doing as a care coordinator or care manager? What is your process, and how can you make that better? And but in general, we do quality improvement projects trying to bridge the gap between evidence-based practice and putting that into your work, helping you put that into your workflow in the clinic.
Great, and yeah, UPIC is located and housed at the University of Utah in the Department of Pediatrics, Division of General Pediatrics. So, great, yeah. So if you, Dawn works across the hall from me. So if you are interested in connecting with Dawn, I can also help you get connected with her around this quality improvement project for caring for families with kids with autism. So great, thanks, Dawn.
Thank you.
All right. Anyone else like to? I mean, this is a time to do announcements or provide some information for the group, just like Dawn did. You can also let us know if you're doing a quality improvement project and you've seen some things that you want to share and inspire us with. We can talk about any hurdles that you're facing with cases that you'd like a little bit of, the crowdsourcing help. You can let us know about past cases where perhaps, something has happened that you'd like to share that's useful, or another hurdle or whatever. We really like hearing about that. So yeah, this is your time. And again, those on GoToMeeting, please feel free to let us know what your questions or comments are.
I have a quick announcement.
Great.
Shriners has a new service line that's an extension of our plastic surgery line. We do have a plastic surgeon on staff who does basic cleft lip repair and burn scar revisions, ear necrosis surgeries, ear reduction surgeries, which are considered cosmetic by most insurances. However, at Shriners, because of our Shrine Care mission, for some patients, that can be actually an affordable procedure. And then we have a new surgeon who's come on board, Dr. Mendenhall, who's going to be doing congenital hand deformity. There's a whole list of those kinds of conditions, which I can supply to you, but just kind of keep that in the back of your mind if you come across any kids needing that kind of procedure. And also keep in mind we're going to host another open house in May, and it will be open to all med staff, all care coordinators, physicians, RNs, anybody who's interested in coming. We'll kind of do a rotating presentation on the hour, every hour, grab a prepared lunch that they have, and it'll be very kind of even flowing and hopefully work with people's schedules a little bit better. So that'll be in May. We'll send out a save the date for that.
Great.
Who's your plastics guy?
His name is Mendenhall.
Oh, okay. I wrote him down as the hand surgeon. So he's doing hand surgery, plastics, both. Okay.
In coordination.
Do you know his first
Dana
name?
Johns. I think it's Stephen. I'll have to check. I'll let you know.
Excellent. That's great news.
Yeah.
Okay, anybody else?
I've got a case to staff.
Great.
So we just recently met with a young man who is quite profoundly cognitively disabled. Mom does really well with him, and he's been dealing with some scoliosis. And he will become combative when they try to get him in the CT tube or in front of an X-ray machine. And whenever he's working with clinical parties, he likes to cling to Mom. He's a pretty big guy, and he's become combative. And anyhow, we're trying to get some films on him, and I'm looking for resources that would either allow Mom in the X-ray booth or include a general anesthesia, because apparently he's got a very high threshold for sedation.
How old is the patient?
He's 17.
Or are they trying to do the x-rays? Because primaries lets the parent go in the x-ray.
Just put an apron on.
Yeah, they just
Primary does let him go in?
Mm-hmm.
Yeah.
Okay.
Shriners will if they...
We do as well, same scenario. And we have the EOS X-ray machine, which is a little bit less constrictive for the patient. However, I don't know what type of X-rays they're trying to do.
That's true.
Wes, is it problematic at all for the family to travel to the Wasatch Front for this?
I think they may have some limitations as far as resources, but I'll definitely throw that back to them. I've been in touch with the local radiology. UBM said they might work with general anesthesia. They said it's kind of case by case, so we're kind of in the early end of it, but I just wanted to know what kind of options there were.
I think with the EOS they can do.
Yeah, the EOS X-rays, it's kind of like a phone booth. They can just stand in there. There's no straps or anything, as long as they're, you mentioned he's combative, but I guess that would just depend on how he reacted once he sees it. The other thing to keep in mind is Shriners has travel assistance through our local Shrine organization. So if what we have, at our hospital, we're able to work for the patient, that's an option. They can do reimbursement for gas money or if it's an issue.
Awesome. Thank you.
And so if Wes feels like Shriners might be the best option when he's done his other research, would he maybe reach out to you about the
You're
process?
welcome to reach out to me, Wes, and this patient would need to run through the outpatient clinic, of course, schedule an appointment through outpatient, and they'll schedule the x-rays, assuming that particular kind of x-ray is sufficient for what he needs. I don't believe we do the sedation x-ray. I'll look into that. And of course, if he's over 18, that's an issue. So I don't know.
I believe he's 17, but they actually called for general anesthesia because he's got a very high threshold for sedation. They've sedated him and no effect.
Yeah, I have a child like that. I know what that's like. Just kidding. I'm happy to chat with you, and we can investigate it further.
Thanks.
Okay, good. Oof, that's what this is all about. That's awesome. Okay. Anyone else?
So, Mindy, just because I also do quality improvement projects when I see them. We had one recently come across where Pediasure is an approved formula. The chocolate was covered, but the vanilla was not. And I said to myself, what? You know? So anyway, so a colleague and I, well, there's three of us are getting together who do pediatric management, and we're looking at the formulas. We're looking at what says it's over the counter versus what's really accessible over the counter. There's a lot of places that won't. You can't just go to Walmart.com anymore and order. And so we're looking at redoing our entire formula approval list. And that's a huge project when you consider how many children have specialty formulas that we
Add
deal
Nourish to that list.
What's that?
Add Nourish to that list.
That one in your dreams, I'm afraid, but because you have to balance the need, and I mean the complete, the Nourish, that's the other one, the Hope. I call it Liquid Gold, but it's something Hope, I think. Anyway, but those complete formulas. I actually have two kids who are on complete, which is...
Well, they just came out with that new one, too, which is nice.
Which one?
So it's through the complete, but it's the... now they have a plant-based and chicken-based organic blend that IHC just started carrying it, but it's a little more comparable to Nourish.
Mm-hmm.
It's pretty similar. So I know I've had a parent that was willing to give it a try because the Nourish is so hard to get.
Mm-hmm.
So anyway, I know that they did come out with one that's more plant-based for parents.
I will take a look at that. Yeah. A lot of the argument is depending on the child's age, can they do just a blenderized diet? And the parents very often will do that anyway because it's tons cheaper and they don't mind doing it. But when we looked at this and said, wait a minute, these formulas are the same code. Why is one covered and the other one not? So we're looking at it, and it's not going to be an easy fix. It's probably going to take us months to figure it out. But that's one of the projects that I'm taking on for one of my goals this year. Thank you, IHC. We just have discovered it's problematic for the members, and we're trying to find out if there's a better way and a better balance to help support the formulas. We won't support, newborns that are going home from the NICU on Similac 24 calorie. That you have to feed your baby anyway. If you're going to have a baby, you have to feed the baby. But it's the difference in these really specialized formulas. And this one particular kid, he won't drink anything else. That's it. And he's 16. So it's been a good project to just start with identifying the barriers, what we have to get through, and how to figure out within the laws and, the equality of coverage and that kind of thing. So, but just, if you got Select Health, send your kids to me.
That's great.
It's a big project, but I'm looking forward to getting it done.
Sounds like there's probably a paper or something in there at the end of that. Well, very cool. Okay, let us know how it goes.
I will.
And that's just tremendous. Well, thank you for doing that. That's great. All right. Anybody else? Yeah.
So Becca and I have a kiddo that we're working with who has Down syndrome, and he's 17, nonverbal, and mom just died. So we're trying to find therapy for that. But a lot of the therapists that we're looking at don't work with anyone that old. So
His sister was looking for some type of play therapy or alternative therapy, and we've had a hard time finding a therapist that's willing to. Everyone says they feel like he's out of their range.
So I had one exactly like that. He is also 17. And trying to get him in a facility outside of the state that would take him. Insurance, they wouldn't. So the one place we were able to get him in, I think it was, I want to say ABS, but I could be wrong. Anyway, we did find one for him, and he's doing okay. He's nonverbal, 17, so he's doing pretty good as far as I know. So, shot maybe.
Okay.
It took a long time for us to find him a place.
yeah, it's been kind of difficult.
It is. It was a really difficult one for me as well.
Are you looking for residential or just treatment? I mean, just outpatient treatment
There are
or facility to live?
Just outpatient. He has his sister's taking really good care of him. She's just looking for some therapy to help him work through.
ABS will go into their homes.
I think he's with ABS, but now I had him talk to so many different places, but I want to say it was ABS that finally took him.
We use ABS a lot. Will they work with kids with Down syndrome that don't have a diagnosis of autism? Will that be an issue getting it covered?
He doesn't have an official diagnosis.
Not of autism, no.
Just
He has
Down syndrome.
Yeah.
I don't know for sure on that one,
Yeah.
but I would
It's
try.
worth a shot, yeah.
I mean, silly question. Down Syndrome Foundation.
We sent him an email. Haven't heard back yet.
They do not respond
Quickly. I know.
They're terrible. They really are. I have tried many times. They don't return phone calls, or they'll tell you they're going to call you back and give you resources, or call the parent. And I've had several where I just stopped using them because I can't. They won't respond. They won't respond. So I don't know if they're just over. That's why I think the one thing that we lack a lot of is resources for Down syndrome. I think that we can definitely use more of those because it's difficult to get help on those kids for sure.
What about contacting Liz Wall up in Park City? Her daughter has Downs, and so she might be tapped into, and she's older.
Right.
Too.
She
And
is
so-
wonderful. She's through Wasatch Pediatrics.
And
she
so
works in our summit office.
she might know stuff just by nature of being a parent. Liz Wall.
Yeah, Liz Wall is a great resource.
Wasatch Pediatrics. She's really
They're
good.
in the Salt Lake.
No, but their clients are really cute.
There's really good dance program for Down syndrome kids through the university. The Tanner with the Tanner.
Yeah, Tanner dance.
Yeah.
Yeah.
Sorry, a 17-year-old live great in that class.
They live here in Salt Lake.
Salt Lake City, and you are?
Salt Lake as well, yeah.
Dr. Party at the Salt Lake Clinic, I understand, works a lot with Downs children, and her office might have some more resources that we don't know. I've sent a couple of newborn Downs and other children just to her as a PCP as well, but it's PARDY.
Know if they have DSPD services?
I believe so, but I'm not positive. I know that they've at least applied.
Okay,
I
so
don't know
I
where
can
they're-
follow up. We've had a few, and Human Services is working on this right now because children and individuals with dual diagnosis with an intellectual disability as well as a mental health need, there is very limited providers. So there's a group of us that just recently released a white paper on it, and administration and the governor's looking at it now. But we have found a very few providers but and I don't know them offhand because they're not listed anywhere like that. Yeah. It's been through. We have about 4 employees that have adults with Down syndrome in our office that have helped us make those connections. Okay. And then if they have siblings, the sharing place is always a great place to refer siblings that have suffered a significant loss of a parent or sibling and such. Okay. But the dual diagnosis, I'll connect with you afterwards because this is an active project that we're working on with the division and the governor.
Okay, awesome. Thank you so much.
I have already mentioned Medicaid or
I believe they have Blue Cross. Yeah.
So, Chuck, Dr. Lisa Sampson-Fang was the one who just updated our Down syndrome module. Do you think she might have any ideas?
Well, she works with Sarah Party, so.
Okay, great. Yeah. Great, Dr. Party. Okay. Good. Yeah, right. She's a good face. All right, well, hopefully those are some ideas for you guys to start with. That sounds like a tough one.
How do they communicate? How does he have like a device or?
He signs a little bit.
There's the Sanderson Center has a list of mental health providers specific for their community that or works with deaf or hard of hearing individuals. So they know some sign language if you can understand that way.
Okay.
They have a whole list of providers, and they'll tell you like what insurances they accept and payment forms, and they're not specific to age.
Okay. So that's great. Thank you.
So Amy Spears mentioned the sharing place. So.
Sorry, what was that?
The sharing place.
Yeah, the sharing place.
Thank you. Oh, that's great. Hey, thank you, everyone. That's terrific.
And Amy Spears also has another question.
Okay, well, we'll just need to keep it a little bit quick. We've got to get to our main presenters.
So her question is: does anyone know of a place that serves a place that severe autism kids can be taken when they become violent and parents are feeling unsafe? This is an 8-year-old with increasing violent outbursts.
Crisis Center, are they in Salt Lake?
Sorry?
Are they in Salt Lake?
So, Amy, Salt Lake City?
Yes.
Okay. When that's happening, they can call the police and ask for a crisis intervention team. And it's between uni and they're trained in autism and other behaviors. And so, unfortunately, the only other way is to go in through emergency right now because there isn't, again, this infrastructure for our individuals that have behavioral and mental health disabilities is trying to play catch up. But CIT officers are trained in that, and they will send somebody out.
And where do they call?
CIT, crisis intervention. It's through the police departments.
Police department.
Amy, did you hear all that?
Okay. Great. All right. Well, thanks, everyone. Those were terrific. Hopefully we can help a little bit with that. So now we're excited, very excited to have Dr. Jennifer Mitchell and Jamie Sellers, who are both affiliated with the Children's Center, come and talk to us a little bit about infant mental health. And so come on over, you guys. We're very informal here.
Well, good. That's how I was going to start the presentation. We are very informal.
Excellent. So there are a number of people who are also, you can't see them. They're on GoToMeeting, so they're listening. Okay. And then you'll see Wes, who is in Vernal, who's with us remotely today as well. So because we have this GoToMeeting connection, we can't do this full screen. We found that the slides don't transfer over to GoToMeeting for some reason. So I apologize that you've got this stuff on the left and you'll have your notes showing on the bottom, but hopefully this is big enough that feels...
Yeah, that's okay. I can, in case, I always give myself cues. Ironically, I never use them, but at this point is more of a, my security blanket, but I have them just in case. I'm like, what was the one thing I wanted to say that I can't remember? So
Right.
I'll have them just in case.
Okay, very good. And the other thing I'll just mention is, so you see the green light by this square. That's our mic for the room. There's also this one that's on, and you're welcome to connect it or carry it with you if you'd like. It does help, I think, a little bit for our go-to-meeting folks. But if you speak clearly toward that thing, generally, that
Actually,
should also
this
be
would
fine.
work. This is what for the speakers in the front.
That one's for the speakers in the front?
Yeah, that's aimed to the front, so that picks up those.
Oh, so that one.
Project to the green light.
Right. And I think it'll be just fine.
Okay. Well, and if there's a way for the people that are listening to communicate that they can't hear, we can adjust. I can step it away.
Definitely. And so if you want to just push this button to advance, or I can do it. If you want to look at me, I'll take care of that for you.
I can do it. That's
Okay.
great.
Great.
I'm going to move this out of the way because I am a bit of a klutz and I don't want to send it rocketing. Luckily, there's no one in the splash zone, so I'll probably be fine. But I'm Jennifer. Thank you for having us. This is my colleague, Jeannie. We're both at the Children's Center. I'm also the current president of the Utah Association for Infant Mental Health. Has anybody ever heard of UAIN? Ooh, a couple people. Fantastic. A few people. If you are interested in UAIN, I'm not going to talk specifically about it, but it really is not so much a resource coordination service, but it's more a portal where there's information provided. And we've really grown in the last year. We got our 501c3 status. It's been around since the early 2000s, but we're really making a concerted effort now to get out to the entire state of Utah. We have annual conferences, and I'll throw, I think, some information there at the end, but if anybody has any questions about UAIM specifically, I'm happy to talk to you more about it afterwards. Okay. Maybe it's down. There we go, it's down on the right. Excuse me, we've got a few of the things that we want to target today. One of them is just really addressing what is infant mental health. It's a word that is getting popularized, certainly in the mental health field, but there's a lot of mental health professionals that have no idea what infant mental health is. So we're going to talk a little bit about that. There's also a request that came through Mindy about really wanting to understand not just what it is, but kind of why is this important to this group in particular and for the people that you're representing by being here. What do you need to know about infant mental health? What are you looking for when the children are in the office? And then we're also going to talk about trying to help you delineate about when intervention is required. The beautiful thing about infant mental health, which we'll get to, is most of the really great work that can be done is free, doesn't cost anything, and as we were listening out there, we didn't hear everything, but the common theme I heard, and that Jamie and I were discussing that we hear all the time, is resources and referrals. There's just not enough people to send your clients, your patients to, and we get that. Same problem for us. But the beautiful thing is that if we catch these things early enough and we educate caregivers and everyone that works with caregivers, then there's an opportunity to cut it off at the pass and prevent the mental health issues as the children are getting older. And then Jamie is going to kind of take over towards the end when my voice gives out. And she's going to help kind of educate some of the specific treatments that are available at the Children's Center. We're also happy to talk about some of the other treatments that are available if anybody has questions that we don't necessarily provide. All right, so first things first. You said did the videos get preloaded?
Mm-hmm. Yeah.
Awesome. Okay.
Yeah, so you click on the Chrome. I've got those ready to go.
Ready to go. Perfect. Okay, thank you. So the acronyms, I don't know what it is about professions, but we just are obsessed with them, and I will own that I have not, broken down that barrier, and we use them all the time too. So if I don't specifically highlight one and explain what it is, please tell me. I'm not trying to make this inaccessible information. But IECMHC is Infant Early Childhood Mental Health. You'll see that come up quite a bit throughout the slides. If you see IMH, that's just the infant mental health. One of the biggest challenges, I think, for this field right now as a whole, I'm going to step out a little bit here, is that there are some misconceptions about what infant mental health is or infant and early childhood mental health. And so this presentation is going to help, I hope, distill some of that. But I also just want to put it out there that in any profession, there's always disagreements among professionals also. So you'll hear something probably different than how I may conceptualize this. My background, I'm a clinical psychologist, but I specialize in parent-infant mental health. And so I always talk about it as parent-infant mental health, and that's not something that's been popularized, but that's my background and my training. And one of the slides, I'm getting ahead of myself, but one of the slides you'll see by Winnicott, who's a famous researcher and theorist in this field, talks about there is no infant without the parent. And I kind of see that. I mean, truly, if you just left an infant there, that infant doesn't survive without a parent, without somebody caring for them. And when it comes to infant mental health, the absence of mental health is what happens when there's no caregiver there. Children learn to talk and to walk because they have a caregiver and a context of a caregiving system to learn those things. The same thing happens in terms of mental health, emotional and social development. All right, so this is really kind of speaking to what I just talked about, that infant mental health is focusing on the birth to 5. That's pretty consistent in the literature you'll hear, but it's also why people started conceptualizing it as infant and early childhood mental health, because obviously 4-year-olds aren't infants. I said what I said just a minute ago about how I conceptualize the parent and the infant together, as really it's those critical years of brain development and early learning where the context of the child and the parent together and what happens as a result of that relationship. That is the infant mental health piece, whether you say it's infant or whether it's infant and early childhood. This is where children learn how to manage and express emotions. I mean, if you think of a baby right now, just think that there's a little baby, 6 months old in front of you. What are you naturally going to be drawn to do? I should have had some pictures, but let's look at that picture in particular. When you see that, what do you want to do? What are you pulled to do?
Smile.
Smile, because the little baby's smiling, right? That's attunement. Child is expressing this affective state of enjoyment or curiosity or happiness or joy, and you want to join with that. And that teaches the child, I am seen, I am known, my experience is being held and contained. Imagine the baby's crying. How do you respond? Yeah, oh, what a beautiful frown. Yes, oh, honey, I'm so sorry, you're so upset. And then the caregiver starts to figure out, what do I need to do to help you? These are probably things you see if you're in Target. They're things if you see when you're in the office, walking down a hallway. These are natural caregiver responses when things are going right. When the caregiver has their own mental health in check, when they're not stressed about how to pay the bills, all of these things. This is a natural system in the same way that kids naturally learn to walk and talk by watching and observing others and by the encouragement. When it's working well, there's little intervention required because we're biologically driven to do this and to provide this for these children. All right. Oh, I almost missed my video.
And I think I may not have gotten all of them. So why don't you just click on that and let's see. I think I
It won't do it unless it's in the presentation mode, but I can do that. Mode, not mood. I can do this and just copy it.
And if you want me to do that while you continue to talk, I can get that going.
I don't mind at all. I'm yeah, I don't see that one. There we go. Apologies.
No, unneeded. You just got to get rid of that. Oh, perfect.
You'll also find that I try not to be repetitive in saying the exact same thing, but I say similar things over and over, show videos, because I think it helps really clarify. When I go to presentations, even though I'm listening intently, by the third time I've really got it. So I try to make sure we hit the big points home.
We set up a situation where we were looking at face-to-face interactions between mothers and infants, and we filmed those, and we would code the baby's facial expressions and the mother's facial expressions. We wanted to understand the relationship between them. After a period of playing and engagement with the infant, we then signaled the mother to hold a still face, to not use her hands, to not talk, and just look straight ahead. And the effects on the infant were really quite dramatic. Right away, almost every infant picks up that the mother is no longer responding. Babies have all these ways of trying to get the mother's attention. When we saw Analia today, she does a fake cough with her mother.
How cute.
They start self-comforting by sucking on their hand. They may lose postural control, and they become increasingly withdrawn. If we can see these kinds of effects in 2 months, one can begin to think about the child who comes from a neglectful home.
If that experience is not changed, if the child's experience of chronic stress does not improve, then that brain can have long-term behavioral consequences.
Okay, play with her again.
Okay. Hi, Amelia.
Well, the good news here is that the brain's openness to experience endures for a surprisingly long time. Sometimes we talk about the brain's plasticity. And the term plasticity draws our attention to the continued malleability of the brain, the fact that the brain is not a finished product and will not be for many years. It means, therefore, that the brain continues to adapt to new experience. So we have learned a lot in the last 10 years. And the Core Teams Project is using that science and applying it in effective ways in devising interventions for some of the most at-risk children in our society.
So you get pulled to respond. I do every time. I've seen this video, I don't even know how many times. And every time when the baby's smiling, I'm smiling. When the baby starts to go, oh, honey, and it's so hard. That Ed Tronick was one of the professors that I worked with in my graduate program. And I remember one of the courses we did all day. All we did was watch video after video after video of the still face design. And I'm telling you, by the end, I was a recent mother, a first-time mother too. I was horrified. I was like, I can't do this work. This is so hard. But one of the beautiful things again about infant mental health is that plasticity piece. That the moment you have these connections, and Jamie and I can both speak to this later when we get to the intervention sections, that all it takes is moments like that for the child to reset, for the caregiver to reset, to remember what they have in each other and the relationship that they have. So there's a lot of hope. There's another one here I'm going to catch.
What do we want for our children? What's our goal? Our goal is to have productive citizens that are going to be part of thriving communities. So how do we get from here to there?
As we grow up and as we move into becoming functioning members of society, our mental health is an important part of how we perform our responsibilities as adults. Mental health can't be separated out from cognitive development and language development and kind of social competence, and they all have their roots in either a very sturdy or a weak foundation.
We certainly know that infants and very young children can exhibit behaviors, emotional behaviors, motor behaviors, which are predictive in certain cases of subsequent mental illness.
What are the early signs of mental health problems?
I think that when people look at children and think about mental health problems, that they have in mind often is the kinds of mental health problems that we see in adults. They're looking to see the equivalent of a depressed adult in a child or the equivalent of a schizophrenic adult in a child. And I think that because of the nature of development, that when children have mental health problems, they just look different.
Some of the early signs of greater risk for mental health problems are usually not called mental health problems by people. They're usually called, things like behavior problems or a child who has difficulty controlling his emotions. Some of these may be early signs of what might be a mental health problem later, and some of it may be just differences among perfectly healthy children.
So what does good mental health look like in a child?
Good mental health looks like a child who's curious and interested in the world and wants to learn and can sit and reflect at times about what's going on. It's the ability to experience love, affection, emotions, get upset when things are upsetting, and bring yourself back into levelness without needing intense intervention.
How do mental health impairments develop in early childhood?
21st century science at the molecular level is very clear that all aspects of brain function are the result of an interaction between genetics and experience. Mental illness, as most people think about it, has a very heavy genetic component. Mental health behavior, personality, also has a genetic component, but it's much more malleable in the face of environmental influences.
Genes and experiences, as far as nature is concerned, are just different ways of setting up operating systems, brain systems, neurons.
What happens when a child experiences what we call toxic stress, severe experiences that can be damaging to its developing architecture? Those toxic experiences essentially create this unstable environment, this unstable foundation.
If sound mental health provides a foundation of stability for a child's development, mental health problems can be thought of like a wobbly table. With a child or a table, there may be many reasons for instability. Identifying which factor is causing instability is the first step towards solving the problem. So how do we restore stability to a child's mental health?
We can detect the early signs of instability. Recognizing what these signs are provides the child with the opportunity then to be placed with healthcare professionals who are trained to develop a more balanced set of skills on the emotional control side.
The prescription is to provide support for parents and in that environment in order to reduce conflict, and that in turn will lead to a reduction in dysregulated behavior in the infant and young child.
Most potential mental health problems will not become mental health problems if we respond to them early. Providing the right kinds of supports and intervention early on will reduce the extent to which this will be a potentially more serious problem later.
All right, presentation done. Right, I told you. It's all explained. Excuse me. I think, now I lost my train of thought, what I was going to say. I'll come back to it. One of the things I love about that video is it really does, again, provide a lot of hope, and it talks about the foundations that are necessary. Now I remembered. I knew if I just talk long enough and come back. One of the speakers in the video that we just watched speaks to something that I was highlighting to earlier, and it's this idea that you cannot separate mental health from all other development in the 0 to 5 age. Because if you do, and notice I'm saying mental health, not mental illness. It is a part of natural development. When you separate that in young children, that's where a lot of the complications come from. I would say, I've never done the data. That would probably be an interesting research project for us to venture into at the Children's Center. I would hazard a guess probably half of the referrals that are coming through because of some developmental lag, whether it's language, not usually motor because those tend to stay in the physical health side of things, but every once in a while those kind of are indicated also. The language development, they're not toileting correctly, the sleep is off, there's something off here. And in all those cases, what we end up focusing on, at least in part, if not exclusively, is the mental health side and helping the caregivers learn how to provide that social emotional support and support that development, because when we do that, sometimes these other things resolve on their own. And if not, there's a better foundation for which to address. A perfect example is when I get a referral, or we get a referral for somebody that has a language delay. And it happens more often than I'd like, that they've been kicked out or fired from speech language, from physical therapy, from occupational therapy, because the child isn't participating in the treatment. So they're now coming in because it's clearly a mental illness or some sort of behavioral problem like they were speaking to there. And what we often end up focusing on is that caregiving relationship, helping the caregiver increase attunement with the child, respond sensitively to the child's needs, whether they be some underlying anxiety, maybe there's past medical procedures, and then when we do that, all of those other treatments are more successful because the caregiver is there to support the child through it. Does that make sense? Or did I lose anybody? Okay. One of the things I didn't say, in addition to being informal, is that I always produce slides. There's way more than I'll ever get to because I like to be able to figure out what we want to focus on while we're here. So I will skip, I promise. I'm hitting the things that are most important. And I can always answer any questions at the end because we want to leave time. This is the theorist that I talked about, Winnicott, that talks about infant and early childhood mental health. And I've already kind of gone through this, but really infant mental health is interdisciplinary, which is what UAIM speaks to. UAIM isn't just focused on the mental health professionals providing this, quite the opposite, and it's why we don't focus on referrals specifically. We want everyone out there to understand and recognize the importance of this. One of the things that UAIM is working in coordination with several different state partners and other agencies is looking at how do we get universal screening for children in pediatricians' office and family care providers. And I really want to bust through the barriers that it's not universal screening for just cognitive issues, language-based issues, screening for autism. It's the social and emotional piece. Because if we're not screening and identifying those, then what I was just talking about can play out. That we overemphasize some of those other areas of development and we forget the ones that are the foundation for which the child learns everything else. So the real emphasis in infant mental health is focusing on the promotion, just making people aware of this caregiving relationship and the power behind it. Then there's proactive intervention, some basic, simple things that can be done at home. It's usually, just minor things the caregiver can be taught. There's little fact sheets you can give out to parents to increase things. There's apps like Room that are certainly promoting things that would be in the field of infant mental health. And then you get to the intervention stage when it's more formalized and usually a mental health professional is involved. This was already kind of alluded to in the sense that when we focus on infant mental health in young children or infants, it doesn't look quite the same. One of the catch-all presentations that I've done for different groups a lot of times is I go through and I say, okay, here is anxiety. Anxiety in the 0 to 5 population, here are the symptoms. And then here is behavior disorders and ADHD, and here's what it looks like in kids under 5. And I go through all of the major diagnoses that we provide to children at 5 and under. And then at the end I said, anybody confused yet? Because the symptoms are almost identical. They look the same. Children have a very limited repertoire with which to express themselves. And so they do that generally 2 ways. By taking over control, right? Or by internalizing or externalizing how they're feeling. They withdraw and retreat, or they give it all to you at once.
Yeah.
But those are the main things that you'll see. That's how they express themselves. Whether they're struggling to focus and learn and they're worried they're going to get punished for it and they act out to avoid it. Whether they are rigid and say, I will only eat out of the green cup and the green bowl. There's so much overlap. And it's why when we're coming in, our jobs as the mental health professionals is really tease out, is this more something that we need to focus on differential diagnostics? Because we do have a significant concern about overarching development or possibly something like autism. Or is this just the child using the limited tools they have to say, something isn't right, and I need you to get that and help me figure out how to feel safe in my own skin, how to feel protected in my own skin, how to make sense of the world around me. All of those things look the same on the surface, but it's our job ultimately as mental health professionals to tease out where we need to focus our intervention on. You're going to have to keep me on target, Jeannie. So red flags, I wanted to make sure we spent a little bit of time because there was some specific requests about what do we look for. I will also say if you turn off the practitioner or the professional and you just observe as a human being, you'll know the red flags when you see them. Something just feels off. Because when you watch that video with the parent who was told to do the still face and not respond, didn't something just perk up inside you and go, oh, that baby looks a little distressed. Mom, why aren't you comforting that baby? Those are some of the red flags. That's that classic lack of attunement where the caregiver is not, for whatever reason, and also in infant mental health, a piece of it is that, I said this before, while the goal is to help the child, ultimately you do that by protecting the parent. You help the parent first because the parent, it's the old metaphor about you put your oxygen mask on first when you're in the airplane and the airplane's going down. And I never understood that until I had a child. And it was in that moment on the flight when we had some really bad turbulence and the things popped down and baby's 9-month-old and I'm like scrambling to put it on my 9-month-old and it just hit me like a ton of bricks. He's not carrying my butt out of here. We're not getting off this plane unless I am breathing and then I can take care of him. And so the focus in our field, it's a misconception, is we don't do one-on-one therapy with these kids. Not at 6 months, not at 6 years. We're looking at how do we help this parent? How do we imbue our understanding and our wisdom and our experience and our training, get this parent to feel supported so that they can do the same things for their child. It's not our job to protect the child, it's the parents. And so ultimately, as mental health professionals, we're trying to help the parent. So excessive crying and irritability, I will say in pediatric clinics, there's going to be a lot of overlap between medical psychosomatic symptoms. There's, obviously if I eat something that doesn't agree with me and my stomach's upset all day, I'm pretty grouchy. And nobody's really going to want to be around me. And again, if you're 2 years old and you haven't made that connection between your internal physical experience and your emotional reaction to those, you're not articulating those really well. When you're especially working with children that have significant cognitive delays or limitations or challenges related to autism, things like that. When I was at a pediatric clinic in Florida, when I had a kid that was coming in doing repetitive behaviors of any kind, especially like leaning on things or head banging, first thing I did was I wanted screens for GI issues, screens for earaches, because I would say probably 50 to 70% of the time it was some medical condition that was causing some of those behaviors. So really and truly, we can't do what we do without support from the medical field also in screening out some of the things. Sometimes they go together, sometimes those behaviors resolve or they lessen. But excessive crying and irritability, if there is no evidence of any medical issue that's causing some distress for the child, that's a pretty big sign that there's something off with could be the child's temperament, could be the parent-child relationship, could be toxic stress in the home, but there's probably something there that's throwing off that social-emotional development. Persistent sleeping or feeding problems, I've hit on those a little bit already. Play. Play is children's way of expressing themselves and of learning. If there's delays in play, we often think, thanks to all of the research that's been out there for autism, we go straight to, there's no play, maybe there's autism. Maybe there is, but there's a lot of reasons children don't engage in play. When we as adults are extremely stressed, some of us are really great about doing things that make us feel good, like reading or watching a show or going for a run, and some of us aren't, and we ruminate and we stress and we isolate, and children are the same. So the ones that have the healthy coping skills are the ones that when they are feeling stressed, throw it into their play. Maybe through repetitive things, maybe to distract themselves. The ones that don't rely on play to get rid of all of the stress that they're dealing with, and when I say stress, it could be something major, it could be minor. Our stress is, can we pay our bills? Can we feed our family? Their stress are, I didn't get what I wanted, and so-and-so is going to take my toy next hour. But they're real to them. They're as chronic and tragic as our issues are. It's just to scale, right? Problems get bigger as you get older. And transitions is another one that gets back to when I said a lot of kids manifest their need for control. If I can only control what I put in my mouth, what I let out of my body, then I am going to use those two things to my advantage to get what I want. And that's why toileting and feeding are the two number one problems in early childhood. Because it's the only things they can really prevent. They can't control much else. They will try like crazy, but at the end of the day, if I want my child in the car, I can pick him up and I can pick her up and I can put them in the car. They don't have a whole lot of control. They can scream the whole way, but it's going to happen. So that's why another kind of thing that on the surface, it could be 18 different things causing it, but at the end of the day, what it looks like on the excessive and unreasonable fearfulness. I think that's a pretty normal one. I'm trying to think timing-wise. I do want to show this video. It's very quick and I'll only show it. Oh, you got that one. Okay. Perfect. Is it this one? Yeah, I think it's this one. Oh, sorry. There we go.
In a child's life is that a caregiver and a child have a falling in love experience. And that experience of joy is invigorating to the body on all fronts and is essential to being able to develop the capacity to care, to be able to develop the capacity to love, and to have empathy for other human beings, and to be able to have moral conscience.
The falling in love experience that initiates secure attachment engages both you and your baby. This process is essentially nonverbal.
That's nice. Yeah, no. You want to smile? No.
Back to that.
When you poo,
When it normally when it's in the other mode, it flips right to this like 30-second segment. I'm not going to waste your time going through that. I'll just say that there's different responses that children can go through when they're dealing with this. And you can see them there at the bottom. Well, it's very tiny, you probably can't. The 3 classes of responses that you can see, one of them is going to be like a hypersensitive or a hyperreactive. Have you ever seen a child that just seems to overreact to the slightest things? That they're just all over the place, scattered, can't really kind of settle and enjoy and engage. There's hypervigilance also, which is the one that, similar that there's an overreaction, but it's usually related to stimuli that's in the room. Their response to things tends to be exaggerated. And there's also a tendency to be a little bit tuned in. You know, I can think of, if you think in a pediatric clinic, there's, you know, the doctor or the nurse may be talking to the parent and the child, and there's the child that's playing in the room normally. And then there's the child that's climbing on everything that can't sit still. The hypervigilant one is the one that may be playing, but is really quiet and just watching or listening, or something said like, oh, mom starts talking, oh, he's not sleeping really well, and, you know, da-da-da-da-da, and the child just kind of freezes. Those are oftentimes the signs of there's something a little bit off there too. And then the shutdown, tuned out. Those are the kids that would probably just sit on mom's lap or sit in the corner and are not engaging in any way. Okay, red flags. Oops, I went too fast. Most of these I've already hit on. One that I haven't, if there's a lack of discrimination. Now, some kids are just super social, and so they want to talk to the doctor, they want to talk to the nurse, they want to talk to the person in the hallway, but they're also engaging their parent too. The one that shows no preference for a parent, or isn't at least checking in with the parent, that's sometimes a sign of a cue, because they're looking potentially for attention in others. The child that gets hurt or falls and trips and doesn't seek out mom. There's circle of security is not something that I have here, but I have on a later slide. This idea that when I get hurt or when I'm frightened, if I have a secure relationship, I've wandered and I've explored my environment, but the moment something goes wrong, I get hurt, I'm scared, I'm not sure what's happening, or just enough time has passed, I'm circling back to check in with my caregiver. So natural exploration in the room, in the waiting room is great, but you want to see that the child is showing mom, like, mom, you still watching? I'm not going to go too far without seeing you. All of those are signs of that mental health, that things are intact. This gets into a lot of prevalence. I'm going to scoot through these. This gets into some of the most common things that are showing up when it looks at mental health issues. The increased risk piece is the one that I want to focus a little bit more on. That when you have that disturbed parent-child relationship, when the attachment foundation hasn't been solid enough, you incrementally are increasing your risk for other illnesses to happen. I would also argue probably physical health, certainly from the ACEs study that does teach us. The link, even though those are talking about adults, they're talking about experiences that happened when these adults were children, and probably having a lack of some of this supportive caregiving relationships to help buffer some of the impacts. We don't need that. If we have time, I can circle back to some of these, but I really want to make sure we get to the end. A lot of children go undiagnosed. You know, it's the crux of our society that I wish we could just offer all these services based on symptoms and not have to worry about diagnoses, but we live in a managed care society. Fortunately, the Children's Center is a nonprofit that will never turn a family away because they can't pay. But we are one small agency in the relation to how much need is out there, so we can't see everybody. And a lot of children go undiagnosed, which gets back to my involvement with UAIM, and the mission of UAIM is that we need to put this information in the hands of everybody, because if we can focus on the prevention piece, we'll really significantly fix the end game, which is less children and families are going to need mental health treatment to address issues that have come up. I can't talk about infant mental health without talking about maternal mental health. That's another really big piece, because if you can imagine that after having birth, I inadvertently showed you a clip that talked about that falling in love period. When you're suffering from your own depression or anxiety after the birth of your child, and you don't get the benefit of that falling in love period, my goodness, all you're stuck with is a screaming baby that is inconsolable, that is just one more thing that you have to do, and it is so hard to take care of and fall in love with somebody when you're struggling in and of yourself and to just meet your own needs, or your own needs are not being met. and especially when there's stigma associated with it. So I think one of the classic things, and I love that there's increased screening for postpartum issues in pediatric offices. I think that's where it needs to be. OBGYNs also, but I really feel that the pediatricians have the relationship and develop this relationship with the families, and these things can go on for a long time. So I love that that's happening. I hope all of the offices are doing that. I'll get off my soapbox now. So learning objective 2 is requiring interventions. I intentionally put some of that into the slides in the beginning because I always run out of time. So we've covered a lot of it. It's going to look like I'm skipping over things. But the general guidelines are when there's distress to the child and others because of the child's behaviors or their functioning, when people aren't feeling, because there's the parents that will come into the office and say, oh, he's not sleeping, but we're managing, and this is what we're doing. It's a parent that seems like they've kind of got it. The parent comes in, nobody's sleeping, we can't get anything done, and da-da-da-da-da-da. That's the parent stress, right? Child may be playing perfectly and be like, I'm okay. But the parent's distressed. That is a big red flag. The child may be fine, but we need to be focusing on the parent because the problems will come if that parent doesn't settle with those issues. Occurring in multiple settings is a thing that we look at too. I would argue that even if it's only happening at home with the parent-child, then that's also probably something that we need to be focused on as mental health professionals because that's alluding to there's either toxic stress in the home, there's some kind of issue in the home that's creating some instability or lack of safety for either the parent, the child, or both, or it's something specific to the caregiving relationship that needs to be addressed. Developmentally inappropriate, this is where pediatric offices are great about screening for things like that. But the other thing is that things are not going away on its own. I love the wait-and-see approach for some things. But when it comes to healthy development for social and emotional behaviors, I do not advocate for the wait-and-see approach. Because at 2 months, if there's a red flag, I can almost guarantee you at 10 months there's going to be a red flag. And at 10 years, there could be a red flag. That the earlier we're focusing on promoting social and emotional development in a healthy way, the greater chance we have at addressing some of these other things. So when it comes to the other delays, the wait-and-see approach of, reassuring parents he's really young, this is kind of still falling in the normal age range of language delays, all of that is fine, but I really want to step back from that approach when it comes to social and emotional development. I want to highlight Help Me Grow. It's a referral. Are you guys using Help Me Grow at all? Great. Good resource. They're constantly evolving and getting more and more things, so even if you didn't have luck in one referral, I encourage you to keep doing it because I know several people working there. They're constantly expanding their database to get more things, and hopefully then the response is that the community starts to provide more things. This just goes into more of what Help Me Grow can do. Help Me Grow can do all of the screenings, including the social and emotional. So if any of your offices don't have access to some of those things, do a referral. It's free for the families, and they will track. If there's any issues, they will hold on to that family until that family is connected to resources. And in the absence of resources in really remote areas, they continue to monitor and check in as just kind of a home base for the family. So I really encourage accessing that resource. It's one of the few we have, especially that's free. So we already talked about promotion, and this is where I think, yes, let's stop here, and I'm going to let Jamie talk about treatments.
Yeah. And I want to go back just for a second to red flags because I was having a thought while you were talking about all of that. And I want to make sure we go back a little bit to not just focusing on symptoms that you see in the office, because there are so many times that kids can hold it together really well for all of us. Even in a mental health assessment, and we don't see any of that, but parents are describing all of these outrageous tantrums and behaviors that we're not seeing. And I just want to always make sure that we're supporting parents when they're telling us about those things, because whether or not they're happening or whether or not this is just a super anxious parent who has a hard time managing normal behaviors, I think it's always really helpful for us to be able to do an assessment to help support those parents with those feelings that they're having about it. But most of the time what I find is that kids are really good at hiding those things, and it all comes out at home. And then eventually, after they've been in my office maybe 5 or 6 times, they have a really huge tantrum. And the parent is like, see, this is what I'm telling you about, this is what I'm talking about. And they feel so much better after that. You can just see the relief that somebody else has witnessed what they have witnessed, and that you understand what's happening at home. And so I just want to go back to that as a red flag, is that it may not ever show up with the child in your office, but if you hear a parent who's in distress or who seems overwhelmed, always refer them, because having a mental health assessment is better than just assuming that maybe they're overreacting. So I wanted to just speak to that a little bit. But anyway, enter the Children's Center or other mental health clinics. What we can provide at the Children's Center is an assessment. So when families come in, we're asking millions of questions and just trying to understand what's going on. We're also, and we haven't talked a whole lot today about trauma, but we're screening a lot for trauma. We always want to know, has the child been through any stressful events or circumstances? Have they been abused? Has there been trauma? Has something big happened to them? We always want to know about that. And so that's another area that we're kind of emphasizing a lot when families come in, is making sure that we're screening for trauma. What we can provide, lots more letters up there, without going into too many details about what those all mean, is just letting you know that at the Children's Center and several other providers are getting a lot of training and specific evidence-based treatment around trauma. So when families come into the Children's Center, we have a lot of different ways that we can help them. So based on the child's age and developmental level, and also what kind of trauma they've been through, we can pick from some of these options and provide the best type of trauma treatment for the child and the family. Some of those are more one-on-one with a child who's a little bit older, and who can process some of those things one-on-one with a therapist. A lot of them are really attachment-based. So like Jen was saying, we are really working on how can we support the parent in supporting the child. So some of those treatments are with the parent and child in the office, really focusing on talking about the experience, talking about the feelings, helping the parent feel more comfortable and being able to provide those consistent responses at home for a child. So we offer parenting groups. The Incredible Years Parenting Group is a really intensive, like a 14-week parenting group that provides, it's more behavioral, so it's just giving parents a lot of really good tools to manage behaviors. And that's also something that we incorporate into our therapeutic preschool program, is an Incredible Years curriculum that helps children manage their emotions. A lot of our family therapy, whether it's trauma or non-trauma, is going to be, like Jennifer said, focused on the parent and child in the room with us together. We're helping the parent understand the symptoms, what's contributing to the symptoms, why they're happening, and finding appropriate responses and more attuned responses to the child so that they can continue to help them. As symptoms change, because we're dealing with really little kids, and those symptoms and diagnoses aren't necessarily going to go away, but they're going to change as kids get older. So we just want parents to be educated and to understand what's going on and how to support their child going forward. And have you all heard about our preschool program? I think that's what the Children's Center is most well known for out in the community. And in our Salt Lake office and also our Kearns location, we have our therapeutic preschool program, which is a really intensive outpatient program for kiddos. We call it a preschool because it's preschool age kids coming, but really what it is an intensive outpatient mental health program. So kids are coming Monday through Friday, 3 hours, either in the morning or the afternoon on our buses most of the time. And they're in a room with teachers who are giving them really intensive social and emotional skill building 3 hours a day, helping them practice transitions, peer interactions, lunch, snack, pottying, all of those things that kids are struggling with. So, if you're working with families that are, saying my kid is going to daycare, but they can't manage this child anymore, or he's been kicked out of this preschool and kicked out of this preschool, and we just don't know what to do anymore. That's where our therapeutic preschool program comes in. Kids can come and be in our preschool in a really supported small group environment where we can help them learn how to manage all of that and hopefully successfully transition into kindergarten with as little support as possible. So I have a lot to offer there. Lots of different stuff going on.
Do you diagnose the problems as well? Like, how many of them, what group of them? It seems like a lot of young kids with those with behavioral issues, it's autism. Is that common? Is that what you guys see? Or
I think a fair amount of our kids are on the spectrum, and we do a lot of that diagnosing, obviously, in our mental health assessment when they first come in and meet with one of us on the therapy team. we're providing a diagnosis. We don't diagnose autism. They have to have the psychological testing to be able to diagnose that. But if we feel like, okay, I think that's what we're dealing with, we're going to immediately refer them for that
You
testing.
do a referral.
Either at the Children's Center or elsewhere, depending on the family situation. So we do have kids in our therapeutic preschool that are on the autism spectrum. It's not always the best option for kids on the spectrum. There are sometimes like ABA therapy, things like that might be a better choice because they need a little bit more one-on-one, and it's a little bit different than what we can provide sometimes. But if it's a child who really could benefit from being in the social environment and has the potential to learn a lot in that environment, they could be on the spectrum and be in our preschool, yeah. We have a lot of kids that do really well in our preschool and gain a lot of skills in that setting too, in addition to whatever else we might recommend.
So one of our GoToMeeting attendees has a question. So how do they coordinate care, or do they coordinate care with early intervention throughout Wasatch Front? And then also any telehealth care?
We don't have telehealth currently, but I was just at a meeting with DHS about how they've offered that as like free portals for people. So we may start looking into that. Okay. We are operating right now at capacity and beyond, but we just got a new CEO, and so we're looking at ways that we could potentially expand. It's not about making more satellite offices, but maybe telehealth is one of those options. So no to that one at the time, but maybe in the future. And care coordination, we love when people will coordinate with us. If we find out it's part of our initial screening, we're asking tons of questions about any prior diagnosis, medical or mental health, any early intervention, and when we can get the parent to sign a release, which we have a pretty good success rate with that, then we make sure there's coordination so that whoever else is providing services is aware of what we're doing. Including, we try to get parents to sign a release at the mental health assessment that initiates a form that goes to pediatricians' offices to say, just by the way, we did an assessment, this is the diagnosis, this is the treatment. That way, if pediatricians or family physicians want information from us, we'd have to get a new release at that point because that's only a one-time release, but they know that it started.
Okay, good. Thank you.
So, how long is your waiting list? And then when you have families call you from, say, Ogden, Provo, or further south, where do you refer them in those areas?
That's a good question. I mean, I think our waiting list is usually several months out. However, if you have a family that is experiencing high levels of distress, and particularly if there's trauma involved, we will always prioritize that. And so we look at that case by case, and if a family is in dire need, we know that we're in this critical time period, we're going to prioritize that. But typically our waiting list is about 3 months for a new assessment. And then the preschool waiting list is
varies,
ever changing, but usually about 1 to 3 months for a spot in the preschool too. So, and then I don't know that we necessarily get a lot of phone calls from different areas, but
yeah, I've looked at intakes and screened intakes at both sites for about 5 years now, and I would say, I mean, there are families that come from out of state for our services. Looks different than somebody that lives 2 miles away from the office in terms of how frequently they can come in. But if it's just assessment and check-ins, then we've been able to accommodate those families. Ogden is not a atypical one for our downtown one. We've got a fair amount of Ogden families that will come down. It's rare that they end up in the preschool because of the transportation barriers for most families for a 3-hour group. Provo less so, but we do have some that come from Provo. We really try to figure out if families are coming from really far away, if there's other places that we can send them. But I will say it's pretty limited in terms of people that are willing to work with very young children. So those are more on a case-by-case basis if we feel like we can find them. Sometimes what they'll do is they'll come in for an assessment, and then we use that information to gauge this is where we'd recommend you go. It's also very hard to try to refer somebody that's 3 with just the parent report over the phone in a 5-minute conversation.
Thank you.
Do you have kids that are in special needs preschool through the school district who also are part of your therapeutic preschool program?
Yes, we do. And we work really closely with the school districts. A lot of times we're trying to coordinate, like, we need this kid to come and be in our afternoon program, can we switch them to their morning program? And we're trying to be in as good a contact with the school districts as we can about that. But yeah, we definitely have kids who are coming to, their early intervention preschool or special ed preschool half a day and to us half a day. And our buses are constantly picking up from all of those different schools and dropping off at those schools. So
I'll just make a note that we have about a minute left before the recording ends. That doesn't mean that it all has to stop.
Can we flip to the next slide? And we don't have to talk about that now, but just so that people that are not here, and everybody can get information about UAIM, so you can find out more. And then I'll stop and we can open it back.
We just had the conference.
Yeah, we just did.
Would that be a good? Would that be the best place or resource for us to get any handouts if we wanted to get some, or any sort of literature?
Yeah, great question. And my hope is yes. There is some material on there, but it's to give history, the board is a very small group of volunteers that most of us all have full-time jobs and more outside of that. So we've struggled, but we just now, one of the things that I did as president was start a new committee that works on social media PR outreach. And so Facebook, Twitter, we have things that go out, just tips on a regular basis that's probably the best, most up-to-date information that you'll get. And I would say as we get more members, more people that are interested in donating, a few hours a year or something to help support these things, will get better.
Your meeting has ended.